Oh, thank you everyone for attending this BritBanglaCovid public meeting. This is our second public meeting. This series is looking primarily around health and social care, because some may argue that they're all interconnected, and knowing that the sheer volumes of people who are dying and health reports of England will say things like how Bangladeshis are more prone to death than others in the context of COVID. So clearly there's more of a need for public awareness campaign, and I hope we are playing our part in that context. And I know many of you are also doing similar kind of thing in your own communities based upon your expertise or whatever way it is possible. However, today's focus has been around health. But just to kind of give you kind of a briefly what has BritBanglaCovid has done so far, so you'll get an understanding of it. We'll build bridges with a London Assembly. I think last month, London Assembly had a COVID response committee, which invited a number of BAME communities, and BritBanglaCovid actually took part on that. Also, of course, build bridges with academics and others and people like yourself to make sure, again, COVID in the context of Bangladeshi communities are being promoted whichever way is possible, regardless of party political stance, really. And no doubt, as you know, more needs doing, and hopefully moving on, we can do a lot more, both in the context of publicity and awareness, as well as policy and campaign. And also, I'm sure that you guys have your own interest on certain subjects. So utilizing subjects, things that you know. However, going back to today's discussion, it is no doubt about health and social care. So it will be divided into two elements, really. First, we are looking at in the sense of some of the problems that we're seeing, both from those who are kind of like dealing with it on a day-to-day basis as professionals, as well as those who are affected by it, such as you being a carer. And believe me, amongst us, we have a broad range of experiences, both as GPs, doctors, researchers, as well as those who are carers, and also kind of have to deal with individuals who are impacted by COVID. So let me kind of put myself on mute for now, and I really hope those who are not speaking to put themselves on mute, so at least it will allow clear communication. And if you want to kind of ask questions, you can do that while speakers had their spiel, and there will be Q&A for sure, both after the first session, which is about problems that we're coming across, and the second session is about ways practically we can think of dealing with those problems. So in a sense of what is to be done, again, there'll be key and new. So there'll be rooms for explorations, and I think it looks like this slightly kind of boutique group anyway. So everyone will get a chance to have your say. So on that note, but obviously it is about health. So let's get the health expert coming at the forefront. So Farhana, I know you've been a GP, you've experienced it, and I understand you've written a great deal about it in your professional and personal experience. What do you have to say around health?
Me to speak. I've been doing a lot of work about improving or establishing communication with at-risk groups for around COVID-19. And so when we think about the people that have the worst outcomes, I find it helpful to kind of broadly think about it in terms of exposure and protection. And so that's protection or lack of protection. So with exposure, simply, it's people who are more likely to have more contact with people, and that's inside and outside the home. So inside the home, we're thinking multi-generational households, people who live in shared accommodation, overcrowding, a family where there's 2 parents and 3 children in a 2-bed flat versus that same family who, if they were in a 4-bed house, that affects the dynamics, the spread of the virus. So that's exposure. And then when we think about protection or the lack of protection, the presence or absence of protective factors that make someone vulnerable, we know that being male puts you at increased risk. We know that being elderly, so being over the age of 70, makes you clinically vulnerable, but actually the risk increases exponentially from the age of 40. and then your underlying health. So that's my bit, as a GP. And we're thinking about the ability of the body to protect itself against infection. And so separately, we can think about, these are kind of individual risk factors, is obesity, pregnancy, and we know that the highest risk in pregnancy are women who are in the late stages of pregnancy, BAME women, and women who have underlying medical conditions. And then people who have what are called, you'll hear the term comorbidities being bandied around. So comorbidities is the presence of a health condition, an underlying health condition that puts people at higher risk of worst outcomes from COVID-19. And so the big ones you'll hear will be diabetes, high blood pressure, heart disease, kidney disease, lung disease. And there's more, but those are the ones that you commonly hear about. And I think it's probably worth spending a moment just talking about diabetes, because we know how common it is in our communities, and it's been found to have a real is a real risk factor with COVID-19. There was a study and it found that South Asians were 20% more likely to die than white people when admitted to hospital, after being admitted to hospital with COVID-19. And that was that was despite the fact that they'd been ill for the same amount of time. They had actually had fewer comorbidities and were younger than white people. And it was found in part, after all their statistical analyses and things, it was found in part to be due to diabetes. So it's an important discussion to be had. And just briefly about the process of it, because I think it's quite interesting, and maybe if we understand it better, it will help improve our diabetic control. That when people become sick with COVID-19, one of the things your body naturally does to try and fight the infection is release its sugar stores to try and get the energy to fight the infection. But intrinsically with diabetes, there's a problem with controlling your blood sugar. And so blood sugars go all over the place, and it kind of, you can imagine there's like lots of this sweet, sticky blood going around your system, and it creates the kind of environment where you get these harmful processes of lots of inflammation and your blood being more likely to form clots. These are the critical events that happen when people become really sick from COVID-19. So when you see that, diabetes often is coexistent with high blood pressure, with heart disease, with kidney disease, these things normally all go together. You can see how there's this increased burden on the body when you're fighting this infection. So that's kind of thinking about the health stuff, but that's not the whole picture. And so actually, there's a kind of broader things which I think of as the environmental bits, which is all plays a part in terms of your health and your outcomes from COVID-19. And so, that includes things like socioeconomic factors, and that's a separate risk factor. Deprivation is a separate risk factor. Housing conditions, working conditions, having front-facing roles. Do you have access to PPE? Do you feel safe at your workplace? Are you being listened to if you don't feel safe in your workplace? So all of these things combine together to make someone more vulnerable. And so when we think about BAME people and outcomes from COVID-19, you start to see that after a while, people seem to tick a lot of these boxes, right? So, and when you hear these discussions about BAME people and outcomes, all of the things that I've said often get boxed into two categories, which is deprivation and poor health. And people say, well, if people generally, there's more deprivation in these communities, so they have worse health and they have these jobs where they can't work from home. And that's basically what it comes down to. But before COVID-19, policymakers have said that ethnicity should be considered separately to socioeconomic factors. And that actually post-COVID-19, there's two separate studies which conclude that the outcomes in Black and Asians are independent or only partially attributable to your pre-existing health and deprivation, which means that then there's something else going on that's putting people at increased risk. There's lots of research. The scientific community is trying to find the link. What's the scientific link that's putting us all at increased risk? So ACE receptors, we don't know. Lots of research being done, nothing conclusive. And the other thing you'll hear is vitamin D, right? We've all heard about vitamin D and we're brown and maybe this is it. Maybe this is the thing that's linking us all together. And in researching for this topic today, I fell into a bit of a vitamin D shaped rabbit hole because there's so much information, and the scientific community is really quite almost split about vitamin D, and it's fascinating. But what we do know is that no causal relationship has been found between vitamin D status and COVID-19. So though the groups that seem to have worse outcomes from COVID-19 will often have lower vitamin D, we don't know that there's a connection between the two. And there are studies being done, and it will be interesting to know what the outcomes are, where they're measuring people's vitamin D status when they come in and then treating them, and then we can see, do people do better with more vitamin D? But at the moment, there's no evidence for that. So, by all means, let's sort out our vitamin D. We know it's made in the skin. We know that dark skin needs longer in the sun to be able to make vitamin D. Current guidelines recommend supplementing with 400 units a day. And actually, you can make vitamin D in this sometime at this time of year between March to October. If you spend a short amount of time at midday, you can make enough vitamin D. So it's a low risk thing. We may as well sort out our vitamin D. But is it enough to say that this is what's causing the worst outcomes? The jury's out, and there definitely doesn't seem to be enough evidence to point to that. And then you're left thinking about the inadequacy of the term BAME, right? So this is a hugely vast grouping of lots of different people who are socially, culturally, genetically, vastly different. And then you come to the questions of ethnicity. Is it a social construct? Is it a biological construct? I mean, I think it's fascinating as Bangladeshis. I think we're the perfect example. My granddad, my brother, was born in India. My dad was born in Pakistan. And I was born in Tooting, but I couldn't find a way to make it. But anyway, if I hadn't been born here, I would have been born in Bangladesh, right? And all in the same place. So we can see how much this changes. And so we know that, pre-COVID and post-COVID, actually, even within South Asians, Indians tend to do better than Bangladeshis and Pakistanis. So the diversity in our health experience is sort of paralleled by the differences in our migration history, patterns of settlement, our economic experiences. So it's a really complex, it's really quite complex, and it's not as simple as, when you start talking about ethnicities and biology. So if we're all so diverse, then what is this commonality that we share? Why is it that Black males are 4 times more likely to die of COVID-19 and Bangladeshis are twice as likely? And the conversation tends to shift from one of race to one of racism. And that's, the editor-in-chief of the British Medical Journal wrote that we can't tackle COVID-19 unless we tackle racism. And COVID-19 has exposed pre-existing inequalities. Before COVID-19, Black women were 5 times more likely, and Asian women twice as likely to die as white women in pregnancy. After COVID-19, it was found that half of pregnant women who were admitted to hospital were BAME, and that's after accounting for factors like obesity and underlying health and living in cities and age. So when we think about this, it's a broad thing. We could probably have a separate whole webinar about it, but it's a complex issue, and I think it's an important discussion to start having. And am I saying that the NHS is a front for the EDL? Yeah, absolutely not. Like everyone, I'm immensely proud of the NHS. It saved my parents' lives more than once, and I've personally had very good experiences of it. But just because we love something doesn't mean we can't recognize when things can do better. So I hope I've given you some broader insights into the bigger picture so that we can move away from these kind of unfair and frankly dangerous narratives that actually it's just poor health, poor finances and poor choices that drive the differences.
Thank you, Farhana. Let's move on to, in a sense of mental health. I know, Shah, you went into looking into this. What is going on in the context of health, most importantly, mental health, in your opinion?
So my name is Shah, and I'm currently training to become a psychologist. I've got 1 year left, almost at the end, and I'm a CBT therapist background as well. And I came up with this pre-COVID, so looking at the views around mental health in Bangladeshi men in particular, so men over 18, and specifically looking at stigma, looking at the barriers to accessing help and support as well for mental health, because I guess the research came about where people from a BME background are less sort of represented in mental health services. So we know that there are mental health difficulties present in the community or in these communities, but people aren't accessing help, and just wanting to find out what it is that would stop someone from reaching out, but also on the other side of it, is it the way that services appear that might stop someone from reaching out for help for their mental health? And I'm just in the process of talking to men. So I've been interviewing men around London, so Bangladeshi men. So the youngest person I've had, he's been 23. The oldest person has been 59. So asking them about mental health and the stigma around mental health in the community, but also I guess what would stop someone from accessing support for their mental health. And I've just got, so my aim was to speak to 12 people and I've spoken to 8. So I've got 4 people left to speak to. So I'm still recruiting for the research. And I can share the details for that as well. But yeah, so I guess a big thing is, I guess around, say, with mental health, and I think that this is something that I had in mind already, I guess, with mental health and physical health, and I guess physical health in the community being seen as more important. So if someone is struggling with their mental health or feeling anxious or depressed, not seeing it as maybe as serious as their physical health. So if I'm feeling anxious or I'm feeling like I'm struggling with my mental health, then maybe I'm just going to crack on like it's nothing serious. I'm just going to keep going. I don't need to speak about it. Like it's something that if I talk about it, then there's like a shame and it's what people will think if I do talk about it. And I think for men in particular, because the research focused on men because of I guess their expectations. So whether it's being like the breadwinner, needing to go to work, and I think especially during this time where some people that I've spoken to have been in the position where they're needing to go to work, like if in terms of income, getting money, supporting themselves and supporting the family, but also there's still being this anxiety around, I need to go out, I need to earn a living, I need to support myself and the family, but I'm feeling anxious about that. But it's like people have felt like they've not got a choice. And I think with this as well is just awareness of mental health, I think in the community, and a pattern that I found, like a lot of the men that I've spoken to have spoken about just recognizing the signs of anxiety and depression, and being able to notice that. And if I do feel anxious, what do I do about that? So some of the men that I've spoken to have said that if they go to their GP, then it's usually that medication is prescribed and that they don't always want to go on medication. And I know that that's not the same for everyone, but I think that's the pattern that I've seen, that people say that it's usually like medication or take this, rather than have you tried like social, like signposting to like a social group or like therapy or a therapy service. And I don't know if it will be quite interesting, but I guess on the side of the doctor or the professional, if someone is coming from a BME background, if people do think about other options, like if there's a language barrier, do they still think about therapy as an option? And I think the language barrier was another thing that came up. So some people, the older person, I say older, 59 is not that old, but it's the older man that I spoke to him in Bengali, and he said that he's always worried that there's going to be a miscommunication and that interpreters aren't always used, or he said that his kids aren't always available to go to the doctors with him. So there's always this worry that it's going to be miscommunicated, and that that the professional won't understand what the person is going through.
Start losing your jobs and realize that the whole family system is in chaos, knowing that once you used to be a breadwinner, now you're no longer the case. In fact, I've written a couple of cases actually on BritBanglaCovid where it's, I mean, what was interesting is that one guy, I mean, actually there's 2 guys. One guy used to be an Uber driver, lost his job. Now his wife is paying for his living. So obviously, come on, when you're working, masculinity kicks in sometimes, and that job is no longer there. obviously masculinity might be there, but obviously it shatters you completely. Now the wife is literally the main breadwinner. And on 2 cases, I've seen just that, where initially wives were housewives. As time went on, wives end up going to work, and now both husbands are employed. Now wives are sole breadwinner. Obviously, it changes the dynamics a great deal. And from your point of view, in terms of mental health, definitely psychologically, I wonder what poor bloke is thinking. Thank you, Shah. So, I mean, Julie, I know. Thank you, by the way, Julie. I know you got direct experience from front line, really dealing with a social care. I know you deal with kind of from the perspective of dementia, as I understand it. But in your world, what is actually going on?
Okay, so I started working in adult social care about 18 months ago as a day centre officer with older people with dementia in Tower Hamlets. And so that entails supporting people, older people with dementia in a daycare facility, which means that they are picked up, dropped off at a day centre in the morning, and then they go home to their families in the afternoon. Now, until COVID, that's what we were doing. We were offering a service which was very specific to dementia and their carers. And so we were seeing people in the centre, we were providing support and running activities and events, both on site and outside the centre with other partners, as well as doing trips and other facilities. And that was a normal thing that we were doing. After COVID came, we had to shut down, like lots of facilities. And so that meant we needed to think about how we were going to support the older people with dementia and their carers in a different way. A lot of families decided that they were going to care for their older people in their homes and look after them without any support from the day centre. But there were some older people who have no family members and were living by themselves. And so they were prioritised by our day centre to be supported by us as day centre officers. So what we are doing currently is visiting people in their homes, making sure that they have medication, they have food, they are eating, that they have shopping, if they need any medical attention, that they get supported to go to the doctor or the hospital, whatever that's needed. We also provide support for carers. So people who are caring for their older people may need a break from their caring responsibilities. And so we go in and support their older person with dementia, and they can have a break from caring. And that might mean spending some time with the older person in their homes, or taking them out, or doing things with them in a safe way, so their carers can have some time off. So this has been our practice during this sort of pandemic. We have seen through our contact that people have died from COVID and non-COVID related situations. And I would say it was 50% of both. Some have died from heart attacks, other people have caught COVID and died in hospital. And so we can see from our own experience that it's had a huge impact on the way that people's lives have been led, particularly older people with dementia and their carers. So that this is what I can talk about, as well as the work that we're doing with King's College London with Chris Tang. I'm one of the researchers looking into the experiences of older Bangladeshi people who might not access advice and information in English about COVID. And we're looking at their experiences and seeing what they're saying about the impact of COVID on their lives at the moment. The next phase will be looking at how they're being supported by their family members, and so we'll be interviewing their carers, but we are trying to find out what is a particular experience of Bangladeshis in East London, so we can actually share that information in a way that might be useful for other people to be able to use.
Sounds fantastic and straight to the point, Julie, and hence I love you so much for it. So there we are. You don't mince your words. Let's move on to Shebul. Shebul, I know you personally have been actually very proactive as a disability activist, as well as carer yourself. Now, you might as well tell us what life has been like for you and for your family.
Thank you very much. Hi, everyone. And I want to take this opportunity to express my gratitude and thanks to everyone doing their research and playing their part, especially people in the medical field. I'm not from the medical profession. Wish I was. My parents wish I was, but I chose the kind of performing background. Yeah, so in 2011, my wife was diagnosed with meningitis, septicemia, meningococcus. It's a very vicious virus disease. Uh, she pulled through the whole process thanks to all the staff at NHS, families and friends and the local community. Um, Unfortunately, she was amputated below the knee and amputated on both hands, so she lost all of her fingers. She had skin grafting, the extent like third-degree burns. Um, she has ongoing renal issues, but she's coping well. There was always light at the end of the tunnel. Now she's walking on prosthetics. She's driving, actually, trying to live the life to the fullest. I personally didn't know anything about caring or anything about that kind of disease or how to live with a person who would not have legs anymore or fingers. All of this was new to me. Um, but especially in this time, as Farhana stipulated before, that one of those people that are most affected are people with underlying health issues. And my wife happens to be one of those people that are vulnerable. But as a carer, it hasn't been that difficult because I had enough provisions in place. So before the pandemic, I was self-employed. Even though I was caring for my partner, I wasn't registered for 2 years as a carer, but previously I was. But due to the pandemic, my wife became a shielded patient, and obviously I had to, in emergency, become a carer again and continue that. Um, I think not from a medical point of view, carers were not having a problem. It was more from um, the government confusing the daylights out of us and interfering where they shouldn't. But I think like what Julian is doing is going out and meeting people who are caring for dementia. Um, that kind of work could be translated in people who care for disabled people or people with who are prone to infection. So my partner is prone to infection, whether it's a pandemic or not. But especially in a pandemic, the family have to take extra precautions. So social life for me is zero. I try to do as much to keep sane and I have good friends, Ripon and other people. They keep in touch, the communication. So it's about how you spend your limited time to keep yourself sane. So talking out, reaching out to people, not to feel that you're on your own. Try to make provisions that are accessible, going for a little tiny walk here and there. Um, because the first part of the pandemic during March and going into May, uh, uh, I was kind of quarantined without being diagnosed with COVID. Uh, and, um, and that was purely because my partner was a shielded patient. So it is daunting, it is sometimes overburdening, but if you have good friends, families, and if you can prioritize your time for yourself as a carer, and accessing those kind of respites that organizations provide, that will help you to deliver your job as a carer for who you're caring for.
Fantastic, thank you, Shebul. I mean, it's great to hear, obviously, from you as well. Now, I know there's been lots of kind of comments kind of left there, Jean. So let's open up the scope for any questions that you want to ask to the guest, or any kind of comments that you want to leave. I mean, Jean, are you there? I know you left lots of messages over here. Yeah, hey, Jean. Yeah. You might as well just this is a small group. You might as well say it really, rather than kind of like comment it. So at least we can get a feel of what's going on and what your thoughts are, and also maybe others may want to also contribute to that as well. So what are your thoughts? Obviously, Jean is saying that there's been allocation of resource from non-COVID to COVID, and also, there are underlying health issues too. So therefore, a lot of people have not been able to access medical care due to the fact that allocation of resources. Farhana, do you have anything to say around that? What are your thoughts on this?
Yeah, sorry. I think Jean's making a really, really important point. And I think that will definitely need to shape our response moving forward, because we know that the harm from non-COVID related deaths and morbidity, so that's illness, sickness from non-COVID due to the pandemic. So that's just exactly as she said, diverting care has had massive impact, and we're going to see the impact of this for maybe years to come. So I think she makes it's such an important point that we don't have this COVID tunnel vision that it's so easy to fall into, and actually we need to look at the bigger picture, and of course that has to shape our response, and make sure we take a holistic approach.
Julie, I'm sure you'll have something to say on this.
Yes, so the people that I mentioned, the ones that were seen as non-COVID deaths, were considered non-COVID because the tests weren't available at the time. They were just counted as non-COVID deaths. And so after testing was available, then we could say that the people who died from COVID were tested. And that's why I made that distinction, not because they might not have had COVID, or it wasn't COVID related, it's just because they weren't counted as COVID related deaths because the test wasn't available then.
Okay, does anyone else want to add anything? Shah or Chris, do you want to say something about it? Or you're focusing solely on your research?
I've got some questions about the access. A lot of people mention access as a key issue, and I agree. I'm just wondering, Farhana, you mentioned, you sort of hinted at this, but that access was, there's an intersection between access and structural racism and various intersecting factors. I'm wondering how much of it is a bottom-up sort of issue for people not having for instance, the linguistic and cultural resources to access, or willingness to access, and how much of it is a system issue, so that not being enough tests available, not being enough PPP available, and not enough and not enough being done to advertise these things when they are available to the people who need them. I imagine it's an intersection of the two things, but I'm no expert on this at all, so I don't know if anybody can comment on
that. I agree. I think it's somewhere between the two. I think when we were seeing those first wave of deaths, and we were seeing that trend unfold, there was a delay between what we could see and it officially being recognised. And the BMA came out pretty early on, actually, for them to say that this is disproportionately affecting BAME doctors, and then wider within the medical community we were seeing that healthcare workers were disproportionately ethnic minority. But then the reflection of that was when the Public Health England report finally did come out. It didn't really tell us anything that we didn't already know. And so I think, as you say, it's a combination between the two, there wasn't access to all these things, PPE and safety and all these things, but then nothing was really being done about it. And we're talking about it now in August, when actually this was obvious for some time. So, and as you say, as a bottom-up response, that's what's prompted me and it seems so many of us to be doing these kind of things. I think it's just a reflection of the fact that if this was being done from a higher level, we probably wouldn't all be doing this.
Yeah, weirdly enough, let me just kind of come in over here. Sorry to talk about my holiday, but at least I realized that there was I did get the chance to kind of see different nations whilst I was just kind of voyeuring in Italy and France. And interestingly enough, that's like literally a week and a half ago, 2 weeks ago. Interestingly enough, when you're in France, the behavior of France, it's really like close to English in a sense that, okay, they are compliant, but not compliant enough. But then, if you guys remember, for example, we were saying to ourselves, actually Boris Johnson was saying something like, oh, don't worry, I know there are so many deaths in Italy, but we won't get to that stage, we'll be fine, we'll be safe. If you remember them, weirdly enough, obviously, if you're looking back now, you see how things are. And whilst I was in Italy, the way locals are responding and behaving and complying with, you know, like all the safeguarding policies, i.e. making sure you keep your distance, making sure you wear your face mask, making sure there's PPEs there, making sure testing and tracing, it's all there. Every single cafe, even a tiny cafe, first thing they'll say, where is your face mask? If not, you won't be going in at all. Secondly, without even looking at people's faces, first object you'll be seeing is a sanitation lotion. And then when you go queue up, they will be asking your phone number and your contact details, and they will scan your temperature. Now, I was amazed and envious of what I have seen in Italy, and then driving to via France again, I was, oh my God, it wouldn't surprise me the number of COVID individuals will be rocking up, no doubt deaths will be rocking out. And then guess what? Got back to Italy, and then a few days after, we have saying, if you've been to France, you'll be quarantined. But let's not forget, we can learn from other places, and we have to learn from Italy. But in order to learn from Italy, you have to follow the Italian way. But the question is the government listening? So I mean, enough of that from me, but is there anyone else who wants to say their fair share before we move on to what is to be done? Oh, did I kind of like shut everyone up or what? All right then, so looks like, go ahead.
Sorry, Ripon, I was just going to follow on from what you said. I think one of the differences in Italy than here is that they enforced a lot of things in a much more draconian way, and people were fined for or questioned by the police if they were just walking outside their houses, which supermarket you're going to, and so on. Yeah. And the question is, you know, how would the communities, or the different communities we have in London, respond to that sort of approach? And would that work? And how would we communicate that? And how would that be translated across? I mean, it's very top down, isn't it? It's saying you must do it. And when you're talking about public health, you know, actually the most effective public health measures are like that. It's just, if you want to stop people from smoking, you execute them if they smoke, right? You force them. But those measures are obviously the least acceptable. And I think you're right. I agree with you. I think they've been very sort of hands off. Oh, you can wear a mask if you want. And that's led to a lot of these confusing mixed messages. And I think Shebul talked a bit about that as well. And also this in other areas, there's a sense that maybe that they're forcing something, that they're putting their noses in where they're not wanted, because we already know what we're supposed to be doing. So there's this balance, isn't there? I think Shebul mentioned like confusing messages on the one hand, and also, you know, look, I know how to manage this. What are you doing? You know, you can't possibly have the same insights I have. I've been living with this situation for much longer. So I think it's a really complicated one. How would I mean? Yeah, okay, we can have. I think the main thing is clearer messaging rather than more draconian policies. But that opens up another minefield as well.
I mean, Murshida Chaudhry, I'm not sure if you want to speak up or I'll do it for you, whichever way really. I know you left a message. Murshida, are you there? Murshida Chaudhry? Go ahead.
Can you hear me?
We can hear you.
I don't think you can see me, but anyway. Yeah, I mean, I was just wondering whether partly the sort of the government's ideological adherence to outsourcing everything was partly responsible for the delay in their response. And obviously they have an ideological adherence to the capitalist way, which is just you know, selling off as much as they can to private companies. So, oops, sorry, I'm just fiddling with the screen. So do you think that played a part in their delay? Because obviously they're putting the market ahead of people's health. So I don't know what people think about that. It's a little bit political.
That's fine. Does anyone want to have a go at this? I'm sure Julie will have lots to say, but go ahead. Any thoughts, any views, any opinions?
I just wanted to say it's becoming a kind of race and a business competition for who should be the leader in vaccination. Like just recently we heard Russia, they came out with it. Just before that we heard Bangladesh came up with something. But it's becoming a pharmaceutical competition, and the sad thing is people that are doing groundbreaking research are not being listened to, and are these vaccines going to go to the right places? And it's just a bit sometimes worrying. Is it to do with commerce than actually saving people's lives? And who's going to draw that balance, and who's going to make sure that it gets to the right places? I find it quite scary, this part of the vaccination stage, where are the most vulnerable and the hard to reach are going to be receiving the right type of medication or vaccination, and are they going to be left behind just because of short change, or they don't have enough? This is quite worrying for me.
Anyone else? Tanvir, I know you've been fairly silent. Do you want to add anything or leave a comment? Anyone else? All right then, so having kind of tried to kind of understand where things are, now the question is, where do we get to, and how, and what can we do about it? Do you, any of you guys have any kind of recommendations as to what we can do moving on? I mean, it will be highly appreciated.
Once again, Ripon, sorry, I'm the kid that keeps putting the hand up. But I just want to touch on the kind of media's responsibility around the world, because after the Times or the Guardian put that kind of ethnicity breakdown from Pakistani, Bangladeshi, it had an effect around the world. I saw some horrific WhatsApp videos. I can't verify where these countries won, but one definitely was in the Middle East, where because Bangladeshi people were named, the one guy was trying to withdraw money from ATM machine, and he happens to be Bengali, and another chap from another ethnicity came out and said, "You are the problem, and you've got to get out of our country." And I think the media, especially when they're very conflictive, and right in the beginning you said to tackle COVID, someone mentioned you've got to tackle racism. And I really believe the media have to be more responsible in how they portray this pandemic and how they portray groups in certain communities, because it has an effect globally, because this is a global issue. And I just want to point that out, that the media has an immense responsibility to protecting lives as well.
Thank you for that. Any other suggestions or recommendations? Ooh.
Yeah, so I think that moving forward, when we talk about risk and COVID-19, I think it's a lot. Actually, I think Shebul's actually covered a lot of this without maybe realizing when you were talking. I think it's really about having a balanced approach and recognizing that the virus hasn't gone away, but there's no zero COVID strategy. So the strategy is that we are opening up society and we have to live with this virus. And so we have to integrate a level of risk management into our lives. And we kind of already do that anyway, right? We leave the house as soon as we do anything, we're constantly on a subconscious level thinking about risk. But now we need to kind of expand that to coronavirus. But at the same time, like what Julie was saying, what we've heard about non-COVID risks, actually we need to be aware that in our efforts to avoid coronavirus, we don't end up harming ourselves in other ways, our physical and mental health. So it's finding a balance somewhere in between, which is a lot of the work that I've been doing. So yeah, I think it comes down to balance and just practical steps of what we can do about it.
I think as Julie mentioned in the comments, it's about getting that idea across to lots of different people from different cultural backgrounds. Risk management is a very abstract idea. How do you communicate that to people who have never heard about this concept of risk management? If we understand it, and everybody probably understands it in a different way. So I think it is about, I think, you know, we're talking to Ema in the last weeks, who does this amazing stuff in Croydon. You know, she's always been saying, yeah, you need it's an intersection of so many different factors. So you need a multi-agency approach. You need people who are experts in these various areas. People like, you know, bring together academics, activists, linguists, doctors, GPs, medical experts, get them together and try and figure out, okay, so how, you know, what are the key things we need to communicate? How do we get them across? How do we support people? Where are the needs? Yeah, as Farhana mentioned earlier, try a holistic approach based on and drawing upon different people's backgrounds.
Yeah, I mean, interesting enough, in terms of how you communicate this, what was actually one of the issues that I came across when I was talking to the other doctor, who's meant to be, because he was in Leicester. He was in Leicester during the second lockdown in Leicester, and he's been talking to his elderly parents very often to prevent them visiting mosques. For elderly folks, going to a mosque is a regular thing, and suddenly a lockdown thing says you can't go to mosque. It is quite hard. And so the really question is, how do you encourage elderly folks like what Chris Tang is talking about, stop them psychologically? The only way, he said to me, I did it by saying, you know, you're gonna have to force them to visualize death, you know, and you're gonna have to have open, direct conversation about death. You'll be dying anyway, but this way you'll be passporting it much sooner than otherwise. That's one thing. And the other thing is also making it clear, according to him, is that even when you die of COVID, no one can visit you to your grave. So, because, yeah, so in other words, so you're kind of like catch-22 situation, isn't it? So that even if you die, we can't touch you because you're impacted and all that stuff. So really, those sort of things, by using visual means and being direct, this is how he did it. So Chris, in your opinion really, and also others, to make sure, obviously, our folks do comply and others to comply, what kind of specific measures that we can actually take to kind of get in people's head that yes, there is responsibility for state, local and central, as well as we can do some things ourselves to make sure culturally we're accommodating to the needs in order to make sure everyone is complying.
I think that's really interesting, really animated explanation of what would you call that? Loss framing. So one way of framing a message is by telling people, you know, scaring people, saying if you don't do this horrible thing's going to happen to you. But actually, you know, when they compare that type of framing with gain framing, where you sort of say, actually, if you do this, you'll get all these benefits. It'll be much better for you in the long run. I think might work better. And I think, so, you know, also bringing in this notion of risk management, if you can communicate how an understanding of what exposure is and what protection is and what the risk is and all of those different things to the people who, you know, rather than seeing them as people who should just follow, you manage to instill in them an understanding that enables them to make their own judgments about risk. And that's very difficult. And I think, you know, particularly if you're talking about communities that have an oral tradition. So if you're coming from, like if you speak primarily, if you're Sylheti dominant, for instance, you're more likely to understand risk in a very different way to people, from scientists, certainly medics, who are communicating from a very written understanding of risk. So to understand, so you need to understand how these people understand disease, whether they understand it as a wind, that's going through the community, and that's how you catch it, and it's connected to this notion of airborne. If you have that understanding, you can make these judgments yourself. And I think, what you don't want is top-down messaging and saying, do this, don't do this. You want to develop a sort of nuanced understanding that enables people to sort of adapt scientific knowledge to their own individual day-to-day. So do I go to them? So that enables them to make, really key, potentially life-saving decisions about, should I go to the mosque today? But also they need to adapt it to a risk scenario that is going to be continuously changing. There's no silver bullet. The vaccine's not going to save everybody, because it's going to be, it's going to get worse, and it's going to get better. Then we're going to have to have more restrictions, less restrictions, and we need to adapt. So we need to develop this as part of our lives. So I think, developing a sense of what the risks are in everybody, and developing types of communication, targeting those less likely to access the communication directly, is also going to be really important.
Murshid, I know you've said a number of things actually. Do you want to share anything in your opinion? I'm sure you've got a lot to say, you might as well say it. Sometimes it's good to hear voices.
Okay, well, I can just read out the comment that I made to sort of agree with what Farhana and Chris have been saying about individuals managing their own risk, and I think as a whole society will sort of incorporate that into their sort of daily lives over time. But I think on a governmental level, there needs to be policies that keep people safe as well. So that that there is a consequence for employers who don't ensure the safety of their employees. And I know I sort of just quoted Amazon as sort of being a culprit in this, and sort of cramming their workers into warehouses, but factories anywhere, sort of hotspots for spreading infection. And I think that's because, again, getting things out quickly and cheaply to satisfy the consumer society is the goal. Which puts people's health at risk, and the majority of people employed in these areas are from so-called BAME communities, who are widely varied, but are at risk of the structural racism that society is built on. Because so I can't remember who it was. Was it Shebul talking about this being a global issue? But how it's sort of affecting people of Bengali origin in the Middle East as well, working there. They're at the bottom of the pile, doing the worst jobs, and no one cares about their safety or their health. It's about satisfying consumer demand. But I think, along with sort of incorporating that communication about how to manage risk yourself in your day-to-day life, given your own circumstances, which is going to be different for everyone, because some people don't have the luxury of living in a 5-bedroomed house with only 2 people in it. So we'll have to sort of manage that ourselves. But there are things that I think the government should do if they really take people's lives seriously.
Any other opinions or recommendations? Please do, far away.
I just wanted to add, I guess this is more just from my own experience of living at home with my parents and my family, and I guess the impact with how things have been the last few months on just thinking about my mum, just thinking about confidence and thinking about her going out, because she used to go out before, even if it's to the shop or to the park. And I think the media as well, I think the point that Shebul made, and just thinking about she's at home a lot of the time, and I guess the media and watching things and the messages that the media give. And I think for her mental health, it's that aspect of going out, getting some fresh air, having a change of scenery, going on a walk with someone, but then feeling, I guess, this anxiety about going out and the risk and the fear of, if I do go out and then what if I catch something, or even if it's like even she asked me the other day, because she's not been out for a while, like, oh, do you have to wear a mask even if you go out? Something like that, that she's not clear about. And I think that, just talking from my own experience, and I think that that confidence, the impact on someone's sort of anxiety levels, even if it is just going out and from staying at home for such a long time. And I think with what you've mentioned as well, Murshida, about work and employers, and if they are making adjustments for people with returning to work, and even with like university, because I'm at uni at the moment, and it's still a bit like up in the air. Are people going back? Are people not going back? Will it be a mix of face-to-face or online? And I guess a lot of students as well in that stage in their life, if they're going to be still at home, are they going to be moving out of home? So it's very unclear, but I just wanted to add the point just around, I guess I'm sure there are probably a lot of families, or maybe more in the older generation of parents or grandparents, who, again, with going out, because some people might not have been going out for so long, and now the idea of that can feel very scary, where there is still a risk, but then it's the other side and the uncertainty as well. Yeah, and again, I don't know, I'm just going on to another point, I guess, with the mosques as well, like needing to queue for mosque. I think, remember the other day, and how the numbers have halved and the capacity in mosques as well, and how that you need to queue up and it takes a lot longer. And I guess I can see it as well, how some people can get quite frustrated from that change as well.
So how has the locals who used to go to mosque often and used to be crammed up, now they can't do that? How have they adjusted to it? From your experience?
I think that I think it's difficult because when I've seen that there are quite a lot of older people. Because I think that someone mentioned it before, like going to the mosque. I think you might have mentioned it, Ripon, about older people and going to the mosque, how religion, it does help so much for people, especially during this time. And even when I've done my interviews, people have said how religion is like a type of therapy for them, like it helps them with their mental health as well. And I think that now, because before, like, I think about it as well, you should just be able to go in and just find a spot and sit down. And now it's like, it almost feels like, it feels bad saying this, but it's almost like every man sort for himself kind of thing. Like, you have to go there really early, you have to line up, or there's not going to be any space. So it feels quite sad that that sense of community, where we had that before, now it's like you have to go there really early, you have to line up, not everyone's going to find a space. So then some people end up needing to go somewhere else, where you want to go somewhere close to your house, you don't want to need to travel a lot further away to go and pray. That's just my own experience. I'm happy that they've reopened. I'm happy that they have reopened, because I can see how helpful and how happy people are that they are able to go and pray and go to the mosque, compared to, say, during Ramadan, when we weren't able to do that. But it feels like there's still something missing. But I guess I see it as being grateful for what we are able to do at this point. But then it's scary if that changes again, because I've seen how helpful it is to be able to go back to pray at the mosque.
Sure.
Yeah.
I mean, in terms of practicalities, is there anything that we can do individually, collectively, or any other action plans, things that we might be able to pursue from now on? Anything that we can do that you can think of? I mean, that question goes to all of you, really. It's more about brainstorming in terms of what we can do, isn't it?
Sorry.
Go ahead.
No, go after you, Farhana. Fine.
Well, I was just going to pick up on some of the points about, well, firstly, Ripon, that you were saying about what the other doctor was saying about fear and how that was really effective. But I think, as Shah's pointed out, that actually this kind of anxiety that everybody's living with, this uncertainty, that in itself is a really pervasive negative emotion that we're all internalizing, and that has an effect on our physical and mental health. So I think it's really important, kind of as Chris was saying about, you know, changing the perspective to, again, I don't know the exact terminology, but, you know, I think that's a more sustainable way. And, you know, and we can see that actually people were terrified with lockdown at the beginning and would cross to the other side of the road and everything. And now everyone's like, we're completely the other end, because it only lasts for so long. So moving forward, I think we need to be moving towards empowering people, yes, with this, you know, individualized, situation specific understanding that we all implicitly have, that we can adapt to our environment. But as Murshida was saying, if we don't have trust in the people that are there looking after us, this is what gives us this anxiety, because in the back of our minds we're questioning, well, actually, is it okay? We're being told that we should be going to restaurants and we should be going and opening up society, but then, you know, as Shah was saying, his mum doesn't know, should we wear a mask, should we not wear a mask, you know? But at the beginning we were told that masks didn't work. So is it any surprise that so many people are averse to wearing it when for so long we were being told that it didn't work? So I think, as everybody's saying, you know, it needs to go hand in hand. And I think hopefully with some more of the grassroots efforts that are happening from a bottom-up perspective, that might help increase trust. So kind of disseminating this message within a community, from a community-led approach, where people see that there's people who they trust, people from their own communities, giving this information in a way that is understandable, that is meaningful, and is applicable to your life. So, you know, if you're going to the mosque, these are the things that can help. Maybe actually, instead of going to the mosque, you could do this, or actually maybe you could do this, and actually rather than just having blanket recommendations. So yeah, hopefully some of the work that we've been doing will help with that. But yeah, I think it's important to keep it context specific.
Hi, Shebul, go ahead.
You know, just going back, and this is a bit of a kind of a, because I'm quite fortunate to be part of an interfaith program where today I attended church. Sundays I've been attending for the last 6 months. I attend synagogues, I attend temples, and my own local mosque as well. And I've been quite fortunate. I used to manage one of the second largest mosques in Tower Hamlets, in Big Street called Darul Ummah. I'm not very observant. I like to study. I come from a philosophical background, and I like to understand things. But going through all of these places of worship, they've taken a full grasp of it. And they've with all the resources they're putting it into hand sanitizers, foods to go out on Meals on Wheels, masks for service users, non-service users. Like today at this service, we had one person that service user who passed away from COVID. Then we had a whole service on how we can protect people if we do open up the church, and how best way to organize, and a lot of stuff is going on. There was a bit of a funny little thing. We, as Muslims, when we grow up, our parents kind of keep ushering us to go to mosque and pray. And religion has kind of experienced plague before. In the time of the Prophet Muhammad, when he was living in Medina, they came across a big plague. And this time round, my youngest son went, look, usually we call people to prayer. So it's a call to prayer. And that's the norm. If you travel to the Middle East, Istanbul, you'll hear the 5 daily calls to prayer. But this time it was a call for not going to mosque and not. So my son was like, you know, he was really happy, you know, officially we don't have to go to the mosque. So it's been a big learning experience, even for people who think, you know, we know it, we're Muslims and we know. I didn't know that there was a call for people not to go to prayer in a time of a pandemic. And there was a valid reason to close the mosque. So it's just amazing. You learn so much, and a lot of reconnection with your roots, with your family, with friends, and a lot of reconnection has happened through this pandemic. Just folks that I just mentioned that.
Perfect. Any other?
I was just wondering, Farhana, should we mention the project that we're thinking about doing?
Yes, yes.
See, just to see what other people think, if it's a good idea. So we're trying to get a little bit of funding for this at the moment, and it's really based on Farhana's idea. She produced this, as we know last time, she produced this guide for how to manage the risk. Essentially, it's risk management, but it's tailored.
Put that link, Farhana. Oh, fantastic. Oh, you already prepared it, obviously.
Yes, we got it. So lifting lockdown GP guide, and it's really great what she's done. She's really taken all of the information that's out there and the advice and sort of taken it. And this has been endorsed by lots of people in the medical profession. So it's a really great thing. So, but the thing is, it's a very long document, and we're trying to figure out, okay, so what can we take from this? We've got some key concepts in here. Mm-hmm. How do we repackage them and get them out there? So our idea is we're basing this on the idea that a lot of people trust GPs as a messenger.
Yeah.
And if we can so we're going to try and sort of take out key concepts, package them for people from an oral cultural background, and then get GPs who speak particular languages to sort of do a little video, and we'll post-produce it and everything, and then try and disseminate it through local media, through social media, through community activists and organizations to try and reach people and hopefully get people to share them. And of course, it would be a more linguistically and culturally tailored view of what's going on. So it's a small step. I'm not saying it's a very big thing, but whether you think, I just wanted to see what people here thought of that do you think that's something that might work, or is it not?
Is it a question to all, Dr. Farhana? What are we?
I think it's a great idea. I think it's a great idea, and especially in the world of, at this time, communication is very important, and any productive and constructive communication is very bad. It's just making sure it gets to the people, and you've mentioned all the protocols you can use to get that message out there, and I think that's a really fantastic idea.
Yeah, I mean, from what I understand, a lot of people are using the initiative to spread the message rather than relying on central government. I think Ema mentioned it so many times, and that's how they did it. Also, grassroots activists on various Facebook pages, I've seen just that the government is doing nothing. We can't wait for the government. We have to do things ourselves. So I've seen lots of videos around medical issues related, whereby individual GPs have done their own way and said, we'll just do it ourselves rather than waiting around. Activists have done that. Happy to do it. I mean, if you want us to do it collectively, Chris, or you want to do it with Farhana, whichever way works for you, just let us know. But in terms of videos, before we go, I do want to show one video though, but I'll leave that to later, in case it kind of, I don't know, brings more ideas for you to run with. Not a problem. Happy to share. But before I do that, is there any other questions or any other actions that you're thinking of or you're bursting to share to this group?
I mean, I come from a performing background. I would love to see a kind of masterpiece show, a theoretical. My background is theatre. And I spoke to Ripon, and I wanted to explore people's life, especially using at least some kind of performing arts, performance at least. But I think it's a bit early now. I think there's a lot of fact-finding and more storytelling, because it's all storytelling, isn't it? It's a lot of storytelling, and if we can put that into motion and get people. But then again, we can only allow 30 people at a time. So it's waiting for the right time. And maybe if you know people who are writing about this stuff, or some type of poetry that we can translate into a play. I'm quite fortunate to be in touch with a lot of practitioners in that industry. I used to own and manage my own theatre company, called the People's Palladium. And we did BAME, where most of our performers were people in hijabs and beards and phobes doing Western European play. Our first play was by a writer called Francisco Garcia Lorca, and it was called Blood Wedding. And it's surprisingly how he had all the struggles in Spain, but we could relate it with him as a Bangladeshi into our hamlets. It's just amazing. And he was fighting for women's independence and rights, and his own struggle with homosexuality in his local community. It's amazing. It's amazing.
Could I ask then, because I think that's really interesting, because I think in Bengali culture there is such a strong actual background of literature and the arts. I think we're quite unique like that in Bengali culture.
Yeah, very, very unique.
Do you think there would be a role, because I mean I think what me and Chris were thinking of, or Chris and the team we were thinking of, GPs talking and very situational, so not make sure you wash your hands for 20 minutes, this is a scenario that's specific to your life. Do you think there would be a role for actual theatre and music? I don't know how this would work with a GP doing this, but just broadly thinking, do you think that would have poetry, right? We have all this access.
I think so. For example, a lot of things, if you see on social media, those long messages that get broken into bit by bit, and then you get to say a word and someone else gets to say a word, and it all builds up to a story. Those are really working well and very interesting, and people like to watch those. It's just having the right substance there, the context there, the right message there, maybe reaching out to good writers that could give their vocational voluntary time. And there are a lot of people that want to do something. They're up there in the kind of entertainment industry, but they want to get down here and reach the people. And I'm pretty sure that if we can, get in touch with some of these good poetry, it doesn't have to be, but I'm just saying, but just getting the right message out. And you can do improvisations, you can do freeze frames, you can even do a song about it. But it's just how you present it and what kind of information you want to give out. There was a lot of animation type of, so there was a leaflet made by the local mosque, and I would never have thought that they would have human characters with a bit with that, but then they started using animations to explain to people and signpost them how to wash their hand when they. So things are kind of changing, and it's nice to see that. But yeah, there's always art's always available in every area.
Actually, Julie, you mentioned something about the Bengali performers out of work. I mean, do you want to expand on that? Are you there?
Yes. Sorry. Yes. The season of Bangla drama is not going to be happening this year, I assume. So there's going to be a lot of out of work Bengali performers, artists, musicians, theatre directors, actors, who could be recruited to either put on events or activities for Zoom, or make videos or YouTube, or to do things that will help us get a message out to people that might not necessarily be hearing the English advice and guidance around COVID-19.
Here's your chance to spread the word, or grab those words, whichever. No? Well, before we go, hello?
Did you hear me about the fact that we've got people who could, in our local community, who could, be recruited to do the public health messages?
Yeah.
Yes, we did. Absolutely. Happy to support. Let me know how. Before we go, I do want you guys to watch a video that I did. It's quite a good one, actually, I must say. Let's look. Let's have a look. And it's quite entertaining, but it's developmental at the same time. Ready? There we go. Can you see it?
Yes, we can see her.
About the old say 1978. Mama Bugurasa, Kunuyan. I can I see Hamadi. So I say my attention. I do the Tegala. You have a like. You have a day. Aida. 80, 84. Arab Lahar, I see this. Different aspects of the অন্যটা মানুষটা আগর কথা কইতা সমস্ত মানুষ নেই পাতে তারা নিজের কেমদিলা হামি দেখা লাগে ওদের নিজের বই নিব নিজের বাই ওরা মায়া করতে হয় তারা আমাদের বিদেশ থাকতা হ্যাঁ রাখি দিলেন বলে আমরা এখানে আমরা কেউ নাই আমরা থাকি ওদের ইয়া দিচ্ছিলেন তারপর তো আমরা ব্রিটেনের মানে করে তারপরে করে আপনি তো সময় তো নিচে বাংলা ইংলিশ আসছে যখন আইরিশ সকল কুত্তান জঙ্গল আসা করতে কুত্তা লইয়া আইতো কুত্তা দিয়ে আইতো এই সময় আমার শরীরে পড়তে কিতা করছে শ্বাস ফলাইতে কষ্ট হইছে তোরাই দিছে গে 6-7 hours or so ঘন্টা 7 ঘন্টা হলো আছে গায় কত স্টেমিগরা খারাপ আল্লাহ তো আমার আশেপাশে আর তো এমনি খবর পাইছি আর কি মারা গেছে পুলিশ তো তাদের তোর খাজে নকল মাসলা হইছি আলাদা কোনা বাদা দিয়ে মারা এটা নরমাল কাজ যে সমাজ দাও কিছু করে না আমরা তো কিছু করে না এটা মনে হয় যে মুখে করে আপনাদের বাড়ি তাইবি মালাবারা মানুষ সব তাইয়া মরম না যারা আসলে মায়া বেশি নাই বা আছে বা আমাদের বাড়ি যারা আছে তাদের পেপার লেগে যায় না আর যখন দেখে রূপ না আমরা আমাদের সঙ্গে করে আর পাকিস্তানে এখন দিতে পারি
So there we are. That's it, really. Do you guys want to share anything? Anything else to add or share? Any contribution?
Really good video. Thanks for sharing it. Yeah.
Slightly developmental, but I thought, why not? Let's do it.
Nice.
Yeah. That's kind of it, really. Anything else to share?
Actually, I just have one more thing to share. That I meant to that I just think it's one point that I think we'll see increasingly from a medical perspective is what is being called long COVID. And these are people who are mild, and we know that within the spectrum of mild infection, there are people who have, you know, a bit of cold and flu, or actually largely asymptomatic. That's the people who are, you know, often spreading it. Bit of cold and flu. And before we get to the hospital and death, there's actually a whole load of people who don't make it into hospital, but are having symptoms. We're seeing now at this stage, increasingly, people who are still having symptoms weeks, months on, and that includes chest pains, heart racing, mood problems, sleep disturbances, fatigue, fever, and it's we don't have much data about it, and I've tried to find what the demographics are, and like anecdotally, it seems to be affecting young people more, people under the age of 55, and it might be something to do with the fact that it might be actually because their immune systems are better able to fight the infection. We don't know, it's just a lot of speculation, but I think it is important to widen the discussion when we talk about COVID risk to the fact that it actually can be a very disabling disease, and it just makes it actually even more complicated now when we talk about risk moving forward, because we're saying there's so many maybes, but actually one of the maybes now includes you could also get this kind of disabling, almost a chronic fatigue syndrome type thing, which might not kill you or put you in hospital, but could put you out of work for 2 or 3 months. And so, yeah, or you may be completely fine. So who knows? It's so difficult. It's such a difficult thing to try and establish. But yeah, I think that's an important thing to think about.
Perfect. Thank you, Farhana. Any other tips? Advice? Nothing?
Read my guide, then you'll get all the tips.
Do, definitely do. What, apart from the what else can I say? Thank you for taking part. Thank you for sharing your wisdom. You know,
thank you, Ripon. Well done for sharing.
Not a problem.
Thank you, Ripon.
See you later.
Bye.
Bye.
Bye.